Hello, everyone. Welcome to our webinar. Super excited for what we have to share with you this evening. I am going to just run this camera here for a minute, and just so you know, I'm a real person here. There's not a robot running this webinar, but I want to be able to see my full screen. So I'm going to kick that off. Thanks for joining us. I'm really excited about this. This is a long time coming in terms of the amount of work that's gone into the information that we are going to share with you this evening. Just a few housekeeping notes. First, this is brought to you by us at Precision Analytical, the makers of the Dutch test, but also FAAREM. So thank you to FAAREM for hosting this webinar. For those of you that are familiar with our testing, do know that now you can get kits shipped directly to your patients at no charge without prepayment. So we've switched that around a bit for those of you that are having to shift towards telemedicine, which we totally understand and want to support. We'll talk a little bit about our testing towards the end. That is not the key question that we're going to be asking tonight. But if you have questions about our testing or about the webinar, here is some contact information. Do know that if you're new to the Dutch test, so the Dutch test is a dried urine test for comprehensive hormones. We've got really comprehensive panels for cortisol and estrogens and androgens and their metabolites and other markers that all go into these comprehensive panels. If you're new to those, we're going to show you a little bit at the end the application with an HRT slant, because that's the topic tonight is hormone replacement therapy. But if you haven't tried our tests and you're new to us, you're welcome to try a handful of them for half price. It's a pretty good way to get to know us and know that once you do that, we have a team of about 10 doctors on staff here who can help you make sense of the results and move on towards treatment and those sorts of things. So we are here to help you. In terms of housekeeping rules, if you have questions, please do submit them. I think what I'm going to do is get through our main speaker here, who I'll introduce in a second, and then we'll pause for a few questions. If we have some big questions, we'll hit those up then. And then I've got a follow-up in terms of testing application just for a few minutes at the end. So my goal in starting this company and what we do is to develop the best testing that we can, the most comprehensive look at your reproductive and adrenal hormones. Another topic that I'm really passionate about is how do we best use laboratory testing to monitor hormones, and specifically with hormone replacement therapy. And that's a pretty complex question with all the different routes of administration, with all the different tests that are available. I've been working on that for 20 years now. And I think the information that we have and the testing that we have, they're great tools for you to have in your back pocket as you go about your practice. But there's a third question that I really wanted to add in the answers to, and that is just the question of, should we HRT? How do we HRT in terms of knowing the risks, knowing the benefits? A lot of people just lack confidence in that area because it's so hard to weed through that information. And so for me, I needed to find somebody who had way more acronyms after their name than I do to really dig into this. And so I went to the best place I could find, which was Dr. Doreen Saltiel. And I said, look, I've got a pretty good handle on this testing thing, although she's been helping me with that as well. But I said, I want you to dig deep, and I want you to really understand at a comprehensive level. And she was already FAAREM trained and educated as an expert cardiologist, but also in anti-aging and integrative medicine. You'll notice that she has a JD after her name, so she's a lawyer as well. So she's one of those overeducated people that is the perfect person to research this topic, write it up comprehensively, and we've done that. And so when this is over, we'll be sharing the document that this lecture sort of comes from. And I think that is a reference you are definitely going to want to have when it comes to HRT. And so what she's going to present this evening is a comprehensive look at the pros and cons of HRT. And I think she's the best person to do that. And she's been really digging deep into the literature. She's smart as they come, and she's a straight shooter. So you know what you're getting from her is an honest, objective look at the data and where we stand right now. So I'm going to come back to how to monitor this stuff when we're done. But right now, I'm going to turn it over to my friend, Dr. Saltiel, and welcome to the platform, Doreen. And I am really looking forward to what you have for us. All right, I'm handing off the screen to her, so she should be able to grab that. And then I will mute myself and let her go as soon as I hear from her. All right, there we go. All right, Doreen, a little sound check maybe. Are you hearing me okay? Can I hear you?
Okay, can everybody hear me?
Yes, I can.
Can you hear me?
Yes, I can.
Okay,
Oh, jeez. Dr. Saltiel?
I'm here. Can you
Okay, go
hear
ahead
me?
and start. We can hear you.
All right. Okay, now we have to figure out the slides. There we go. And now we've got the slides. Hi, everybody. It has been a very long time since I've given a webinar at FAAREM. As Mark just told you, I practiced medicine for more than, 35 years. And throughout most of it, I had wished that I had more time to read like we all do. This past year, that wish came true. And in addition to maintaining and continuing my growth as a cardiologist, I wanted to further my growth and development as a hormone expert. And that's exactly what I did. And at the end of this journey that I took, I am humbled by hormones. I realize how difficult a hormone practice is, and I changed my own thinking about hormone therapy. And what I'd like to do is just give you a snapshot of basically what I learned so that you can use these tools in your toolbox when taking care of patients. Now, there's a lot of literature out there. Here are our objectives. There's a lot of literature out there, and the reality is it's hard to read it all, and in fact it's hard to understand it all. And so what I try to do is actually group things together for you such that you have references that you can go to and use clinically. So before we do anything, I guess we should define menopause. It's a cessation of menses for at least 12 months. And really what we're going to talk about is also going to apply to perimenopausal women. So traditionally, the primary indication for hormone therapy is symptoms. Well, as we go through this, you'll see that there are more indications for hormone therapy than just symptoms. But as you know, vasomotor symptoms can last a year, or they can last many years in many women. So let's dig in, guys. We know that estradiol benefits vasomotor symptoms, improves vulvovaginal atrophy, prevents osteoporosis. I have question marks next to cognitive decline, which we'll talk about in a little bit. But realize that, and what is really important and what hinders people in prescribing hormone therapy are the risks. Everybody's afraid of the risk of endometrial cancer, for example, and all the hype that surrounded breast cancer, and then the hype that surrounded cardiovascular disease. So we're always balancing how you optimize these while minimizing these. And I think if we address the risks, the benefits will just stand on their own. The literature is very clear on the benefits, and I don't think any of us will argue about the benefits of hormone therapy. So let's start with endometrial hyperplasia and endometrial cancer. What I did is I grouped it according to outcome. And for the endometrium, it's really all about progesterone and progesterone dose. So if you were interested in studies surrounding 200 milligrams of oral progesterone, there are 3 good studies that you can use as a reference. And I also put the weight of the evidence for you. Now, not every randomized controlled trial is a stellar study, and not every observational study should be poo-pooed. They're both good studies. You have to read the studies or read the papers Mark was talking about, such that you can glean and use this information to best take care of your patient. Well, when we talk about endometrial hyperplasia and cancer, the landmark study is the PEPI trial. It was a 3-year intervention trial, recently menopausal women, and they looked at 5 regimens. But for our purposes here, we're just going to talk about the estrogen alone arm. And as you see early on, all anybody used was conjugated F1 estrogen, which is Premarin, the standard dose of 0.625 milligrams. And what they found in this group, when they compared it to a placebo, is that at 1 year there was 20%, and at 3 years there was 60% increase in endometrial hyperplasia. And so nobody gives women with a uterus unopposed estrogen, and I don't think most of us, even women without a uterus, do unopposed estrogen. But when you're talking about the endometrium, it's all about progesterone. And these are the studies that you're going to want to know about and you're going to want to keep in your back pocket. Now, Gillette used as you can see, a high dose of Estradiol, which is the European version of our US Estradiol without the O, and 100 milligrams of progesterone. This was not an endometrial hyperplasia study. They looked at mitotic activity. It was a short study, only 6 months, but it did inhibit mitosis and it did induce amenorrhea. DiCarlo had a larger observational study. It was a 1-year study, but interestingly, DiCarlo used a standard dose patch with 100 milligrams of prometrium for 12 days, in addition to other regimens of oral prometrium, 200 milligrams, vaginal prometrium, 100 milligrams, or 200 milligrams, both for 12 days, and all of the regimens protected the endometrium. Prometrium 100 milligrams orally, prometrium 100 milligrams vaginally. Fernandez-Merger used a 0.025 milligram patch, found no statistically significant increase in endometrial hyperplasia. And then the Replenish trial actually is Bijuva, the recently FDA approved 1 milligram of oral estradiol with 100 milligrams of progesterone, and it too protected the endometrium. There were 3 other regimens in addition to a placebo arm, which was a 0.5 milligram of estradiol and 100 milligrams of progesterone. And there was the 0.5 milligram of estrogen with 50 milligrams of progesterone. And then there was a 0.25 milligram of estradiol with 50 milligrams. All of them protected the endometrium. I'm not recommending you use 50 milligrams. The bottom line is, these authors said a couple of things. You must balance your progesterone dose with your estradiol dose. We're not going to use oral estrogen, but this is just to make a point. They also found that baseline serum E2 levels or Dutch levels greater than 0.5 to 0.6 nanograms per milligram at baseline increase the likelihood of endometrial proliferation. So that's important when, number one, dosing progesterone and whether or not you need further testing. Doreen, why aren't you talking about compounded estrogens? That's what some of you must be thinking. I use compounded estrogens. The reason I'm not talking about them, there are no studies. All of the studies used either an estrogel, Divigel, or a patch. 200 milligrams definitely protects the endometrium. And this is what guidelines recommend. 200 milligrams. Why? Part of it is that there were 2 randomized controlled trials. The predominant one is the PEPI trial, and then there was a large observational study. The interesting thing about the Moyer study, again with 1.5 milligrams of estradiol, is that he started looking at endometrial biopsies as of 8 days when the women were on 200 milligrams. And what he found is that you needed greater than 11 days of progesterone use to protect the endometrium, hence the 12 to 14 day recommendation that when those of us who use sequential progesterone use it for 12 to 14 days. Well, what about 45 milligrams? Well, Ziegler didn't really set out to look at predominantly endometrial hyperplasia. The thought was it protected the endometrium. They knew that 90 milligrams, which is the quinone 8%, induced the secretory endometrium. It's used in fertility clinics. The question he asked is, number one, would compliance be better with a vaginal progesterone, excuse me. And number two, would there be less bleeding? Because one of the reasons women stopped hormone therapy was because of increased bleeding and or side effects. And the answer to that question was yes, this was better tolerated. Transvaginal ultrasound was done at the end, and on the individuals, the women that they did biopsies on who had increased endometrial thickness or bleeding, there was no endometrial hyperplasia. And so the conclusion was this is a reasonable alternative. The ELITE trial, which we'll talk about later, which is a cardiovascular trial, used 45 milligrams with 1 milligram of estradiol. HOTUS didn't want any progestogenic cardiac effects to interfere with the estradiol effects because he was part of the timing hypothesis. At least the ELITE trial tested if you give women hormones early versus if you give them late, would there be cardiovascular benefit? But what about transdermal progesterone? It shouldn't be used to protect the endometrium. There are a number of studies, not a ton, but a commonly cited study is the WREN study. WREN took 26 postmenopausal women and primed the endometrium. And what he was looking to see is whether these doses of transdermal progesterone, non-vaginal, placed on the skin would induce a secretory endometrium. And the answer to that was no. Not only did it not induce a secretory endometrium, there was no progestogenic effects at all, and there was evidence of mitotic activity. Part of this study, he looked at serum. Serum didn't move a whole much, consistent with no progestogenic effect on the endometrial biopsy. And he looked at saliva. And the saliva numbers were all over the place. There was no relationship to what was found on the endometrial biopsy to what was found in saliva. He concluded salivary testing is not helpful when you use transdermal progesterone. FACC is the other study, and they used 1 milligram of estradiol with continuous transdermal progesterone, 40 milligrams. And really, he found that it was inadequate. The 40 milligrams was inadequate to balance the proliferative effects of transdermal estradiol. But more importantly, when you think about this, 32 out of 100 women had either endometrial proliferation or endometrial hyperplasia. When if you look back at the PEPI trial, there was a 95 to 99% success rate. Whereas here, there was only a 78% success rate. I would not find it acceptable to use transdermal progesterone on women if I knew that 32 out of 100 would develop endometrial proliferation or hyperplasia. Well, Leonetti is the study that most proponents of transdermal estradiol cite, transdermal progesterone cite. She conducted 2 randomized controlled trials. One was using transdermal progesterone 20 BID versus placebo. That was a 2003 study. And the question was, does it work? And the answer was yes. It protected the endometrium. Then in the 2005 paper that she published, this was a crossover study where women used CEE 0.625 plus MPA 2.5 for 6 months, and then crossed over to 20 milligrams BID after a washout period with the same CEE dose. And indeed, it protected the endometrium. However, she does not recommend using progesterone cream as an alternative to other progesterones. And she states this very clearly. Until longer and larger studies are performed, we do not recommend progesterone cream. Most proponents leave that little bit out of their story when they're telling the story about transdermal progesterone and the endometrium. And to date, as I said, there are no larger and longer studies, so she still wouldn't recommend it. So just looking at some key points here, this is a no-brainer. Don't use unopposed estrogen in women who have a uterus. And important is the dose of estradiol will determine the OMP dose. Serum levels may be helpful. Studies document that oral micronized progesterone definitely protects the endometrium. And I put here probably, and that's based on the data. There are no randomized controlled studies. They were observational studies, and they were not long-term studies. And that's why I put probably. I use it all the time. Studies document that vaginal micronized progesterone, 100, 200 protect the endometrium, while 45 probably protects the endometrium. Hodis felt comfortable enough in the ELITE trial to use vaginal micronized progesterone. There were no adverse events noted in the 5-year study. And to date, there's limited data on transdermal progesterone. So I think comfortably using 100 milligrams or 200 milligrams, we don't use doses of 1.5 milligrams of estradiol. The doses that we commonly use are lower. And so I think you could be very comfortable using either one of these. In addition, vaginal micronized progesterone does work. That's a decision between you and the patient and their comfort level with using vaginal creams. And they also need to place it in the right spot. It needs to go in the upper third of the vagina, as opposed to where you would put estriol or even testosterone. It needs to be placed in the appropriate spot, basically, to work. And transdermal progesterone, I think, is not ready for prime time. It should not be used to protect the endometrium. Not good studies. So my hope is that I've demonstrated that endometrial cancer is a risk with estradiol, but we know how to mitigate that risk. Progesterone, oral or vaginal. What about breast cancer? Well, this is fairly complicated, and this is where most of the data gets all confusing. We all know about the absolute contraindications. You're not going to give hormone replacement therapy to those women. What about relative contraindications? Here, it's between you, the patient, their risk factors, and really deciding what is in the best interest, and pause, think, and then act. So here what I did is I grouped the studies, once again, according to outcome. And what I want you to see is that there is a grouping of studies around estradiol decreasing breast cancer. And I will constantly use the term estradiol because none of us are using estrogen. And most of what I'm going to refer to is going to be transdermal, and you'll see how you can extrapolate data and rationalize data. And then we'll talk a little bit about the two studies that everybody cites as increasing breast cancer. Well, the WHI was a political nightmare. Its primary purpose was not to evaluate recently menopausal women. It was to take the benefits seen in premenopausal women and see if it translated into older patients further from menopause who are more at risk of chronic diseases. Unfortunately, because of politics, the original investigators didn't write their initial papers. The papers were written by a small group, and actually the original investigators were stunned that the papers had been accepted and were being published without their input. They put breast cancer in the forefront. And what they said and had continued to tout was that there was an increased breast cancer risk 2.5 to 3 years after randomization. There was nothing about CEE alone. They clumped all the data together, and the CEE and MPA received all this attention that hormones increase breast cancer. Well, since that time, there have been a number of reanalyses, and I really like the one that was published in 2018 by Hodis and Sorrell. It is very easy to read, and it's very easy to understand. And on their reanalysis, what they documented, and others have documented as well, is that in the CEE alone arm, there was a 45% statistically significant breast cancer mortality reduction after 18 years of follow-up. Now, remember, these women were not treated for 18 years. Treatment was stopped in the CE alone group at about 7.1 or 2 years, and in the combined group at 5.6 years. And what they found in the combined group, that in reality, there was a null effect on breast cancer incidence. And where all the hype came from was that one placebo group had an unusually low incidence of breast cancer. And let me show you this here. If you look at the left side of the screen, you will see that this is the treatment arm and this is the placebo arm, and this is the annualized rate of breast cancer in women who are hormone naive before they entered the study. And you see that there's essentially no increase in breast cancer. But what about when you come over to the right side of the screen? These are women who had been previously on hormone therapy, agreed to stop their hormone therapy, which a lot of women were unwilling to do. And those women were randomized to either no hormone or combined hormone. And the first thing I want you to do is just focus on the blue line. And if we lift up this blue line and just place it along here, you will see it lays almost right on top of the placebo arm in that hormone naive group. And what the real issue was is that this placebo arm had an unusually low breast cancer rate. And they validated this by comparing it to all the other WHI studies that were going on. The WHI observational study, the WHI vitamin D and calcium study, and the vitamin D and dietary and lifestyle study. And indeed, all of the placebo arms look more like here. None of them look like this. To date, there's been no explanation of this. But instead of saying this was an unusually low breast cancer incidence, they instead said this group has an increased breast cancer incidence. And if I take this one step further, normally to determine causality, you have to have a drug, and then you have to have the outcome of that drug, the causation of that drug, something happening because of the drug. Well, it takes about 10 years for breast cancer cells to become clinically evident. So how do you start women on therapy and then blame it on the drugs when the breast cancer incidence started 2.5 years later? It's biologically implausible. And you'll see others do this also. And then in 2017, Joanna Manson, who was part of the original investigation, notice they say that now whenever they're writing, is that there was no associated risk of all-cause cardiovascular or cancer mortality during the cumulative follow-up of 18 years. So I think that the WHI study needs to be put to bed and shouldn't be used as the groundwork of where we pivot on whether or not we should use hormone therapy. What about decreased breast cancer mortality? Well, DOPS was published in 2012. Well, what's DOPS? It was the Danish Osteoporosis Prevention Study. They looked at as secondary outcomes both breast cancer and cardiovascular disease. These women were treated for 11 years. This again was the timing hypothesis. They were started soon after menopause, treated for 11 years. It was supposed to be a 20-year study with follow-up for 16 years. Again, they used oral estrogens and progestins, and what they found was a statistically significant decrease in breast cancer and breast cancer mortality. But what about the FINISH study? Well, the FINISH was an observational trial, and they used drugs similar to what we use, all 17-beta estradiol based, all bioidentical. It was either orally to patches of 0.25 to 0.1, or gels 0.5 or 1 to 1.5 milligrams, recently menopausal. And what they found is that the E2 alone group had the greatest breast cancer mortality reduction. But in all comers and all hormone users, breast cancer mortality was significantly reduced even when it was used for greater than 10 years, with the largest mortality reduction between 5 and 10 years. They also noted that the age at which you start hormone therapy was not related to breast cancer mortality. So this poo-poos a lot of what the WHI has led everybody to believe. Well, what about estradiol and increased breast cancer? Yes, no, maybe? Well, the Million Women study is commonly cited. This actually is a poor study. It was published in 2003, and all of the data analysis that was performed on the data gotten at recruitment. This was about a 5-year study. They never updated the files when they saw women in follow-up. They noted that when you added a progestin, the risk was greater. So again, progestins are gone. But it didn't matter whether you used transdermal estradiol, whether you used estrogen, whether you used oral E2, whether you used pellets, whether you used creams. There was an increased breast cancer risk and the risk of death. But similarly, diagnosis made at 1.2 years. And these women died within 3 years. Well, most do mammography more often than every 3 years in women who were treated with hormones. But these women had pretty advanced disease. If they developed the disease 1.2 years and then they died. Again, give the drug, 10 years, around 10 years, you could say 7, you could say 8, but it takes about 10 years for breast cells to become clinically evident. The only way this is possible is if the women had underlying breast cancer to begin with that was not diagnosed. Additionally, more than a third of the women use more than one regimen, so the data is not clean. And similar to the WHI, the control group had a lower breast cancer mortality than a similar general population. So any increase could be viewed as a statistically significant increase, even if it was not. Well, E3N is the European study that everybody cites, and what they found is there were 3 publications. The first one was a pre-E3N. These were hormone-naive women a year before entry. They were recently menopausal. They used it for almost 3 years, followed for almost 6, and transdermal estrogens led to a small increase in breast cancer. Once they added oral micronized progesterone, the risk was eliminated. And again, we're going to forget about progestins. This study, the Europeans mainly used transdermal estradiol products, mainly. Whether they used OMP or a progestin was about 50-50. But the real first study that came out was the 2008 study, which documented a statistically significant increase in breast cancer with transdermal products. But when they added OMP and dydrogesterone, which is similar, the breast cancer incidence neutralized. What they decided at the end of this study is that it really wasn't the estrogen that determined breast cancer risk. It was the progestogen. And then in 2014, they analyzed the data after the drugs were discontinued. They were stopped in 2008. What they found is the risk persisted. But it was here at the end of this study that they said, don't use oral micronized progesterone more than 5 years. You're going to increase the risk of breast cancer. Well, guess what? Women used more than one regimen. They changed categories. Some never users became users. Some users became never users. None of this was accounted for. And what I found striking is that in the E2 alone group, the transdermal E2 alone group, 72% used a progestin combination. In the E2 and OMP group, 57% used the progestin. So the data is not clean. So it's hard to say that these studies increased breast cancer. What about progesterone? Well, D. Ligneris was probably the first to publish this long-term study of basically combined hormone therapy using gels and OMP. Unfortunately, we don't know the doses. It was an observational study. They followed women for up to 24 years. About 8.9 was the mean time. And what they found is there was no difference in breast cancer between controls and those who were treated. But more importantly, there was no difference in those women who had used hormone therapy for greater than 10 years than those who used it for less than 5 years. SB published the Mission trial in 2007. Again, transdermal estrogens with either OMP or progestin. This was real life. The OBGYNs determined what drug and the regimens that were used. Again, recently menopausal women. No increase in breast cancer, even when hormone therapy was used for greater than 10 years. So I think we can be comfortable saying that progesterone, OMP, does not increase breast cancer. I think we also can be comfortable in saying that when you continue it for greater than 10 years, certainly you got to be cautious. You got to do surveillance. You got to monitor people. But you don't have to stop hormone therapy at 10 years, that it is safe. Evidence that TD alone does not increase breast cancer, and there's no evidence that OMP added to transdermal estradiol increases breast cancer. Both these studies need to be interpreted cautiously, or for those of us who are proponents of hormone therapy, this is a tool in your toolbox. The data favors hormone safety and decreased breast cancer with TDE2 alone. All commonly used patch and gel doses that we use decrease breast cancer mortality. 0.025 milligram patches, if you use a 0.5 milligram gel, if you use a cream that you had compounded, you're going to extrapolate the data that we just looked at and document the chart. Transdermal estradiol and OMP are safe for the breast. Age when you initiate hormone therapy, according to the finished study, doesn't impact breast cancer risk, and the doses of OMP that we used to protect the endometrium that we need are also safe for the breast. So I hope with that quick but brief overview that I've at least convinced you that breast cancer is benefited by estrogen therapy, or the breast, it's breast protective, and it's safe. So all we have left is cardiovascular disease, something I know a little about. Estradiol definitely has cardiovascular benefits, both direct and indirect. It increases ENOS, nitric oxide. It decreases plaque progression. Indirectly, decreases homocysteine, which is an independent risk factor. It affects lipids. Really, it affects inflammation. It's an immune modulator. And it also impacts endothelial cells, smooth muscle cells, and cardiac myocytes itself has estrogen receptors. And before the WHI, all of the observational studies said there was a 40 to 50% decreased cardiovascular risk in recently menopausal women. This treatment was a low-risk intervention, and you got the biggest bang, really, for your buck. The question then became, will this translate to older women who are more at risk for cardiovascular disease than recently young, healthy, menopausal women? In the CEE alone arm, and I'm just showing you, none of us use conjugated F1 estrogen, there was a small but statistically increased risk of stroke. And in the combo arm, there was an increase in venous thromboembolic events. I group these the same way. Studies with mixed results, studies that document no benefit, no harm, and studies that document benefit. Well, let's start with the reanalysis of the WHI-CE alone arm. Only about 10% of women were between the ages of 50 and 54. About 20%, 18% were between 54 and 59. The remainder, the majority of the women, were between the ages of 60 and 70. And what they found in this recently menopausal young women is that there was a 45% decreased MI and all-cause mortality rate. As women got older, not surprising, inflammation increases, vessels stiffen. Between the ages of 60 and 70, there was a neutral result effect. And in the very small numbers that were 70 to 80, there was a trend towards an increased risk. Now, remember that the placebo group of the WHI were younger than the actual treatment group. So again, your risks were lower. And then, as we talked about earlier, Manson, when analyzing all the data, the original investigators found no increased CVD mortality. The ELITE study is a very interesting study. They looked at really the timing hypothesis. If I initiate hormones less than 6 years post-menopause versus greater than 10 years post-menopause, will there be a difference in cardiovascular events? Well, but they didn't look at events. They looked at surrogate markers. They looked at CIMT and coronary artery calcium. And what they found is at less than 6 years, this was published in 2016, there was a statistically significant CIMT slowing, but only at 5 years. Women who were greater than 10 years postmenopausal, there was no difference in the rate of CIMT progression when compared to placebo. Recently, in 2019, this is an update. They looked at, or they analyzed, the serum E2 levels and its impact on CIMT. And what they found is that in the early group, less than 6 years postmenopause, higher serum levels led to less CIMT progression. Same dose, both groups got 1 milligram of oral estradiol, which we don't use, and vaginal micronized progesterone. And what you see here, that at the end of the study, the mean serum E2 levels were 48.2 plus or minus 35, with a range of 12.4 to 84. But more interestingly, in the late group, the higher the serum E2 level, the greater the increase in CIMT progression. So this should cause pause, really. And you want to keep, if you're going to continue hormone therapy, you really want to keep them not anywhere near a premenopausal range. This was 16.6 to 63.8. You're going to want to keep them, if you use urine, on the lower side of the Dutch range. Keeps 4-year study. These were extremely healthy women. 0.05 milligrams of Clymara, standard dose patch. 0.45 of Premarin, 200 milligrams. They found OMP was safe, no adverse events, but the most important thing is coronary disease is a chronic disease. It is a slowly progressive disease. And in women who were like super healthy, I mean, they had no coronary artery calcium, zero. They had no, literally bits of intermedial thickening. I mean, these were the pristine, healthy women. You would expect it to take longer than 4 years to see anything. And with ELITE, these women were healthy, but you could say they did have subclinical coronary disease. They had a little bit of coronary artery calcium. Their study duration was 5 years, which was when it was picked up in the early group. But now we need to add serum, layer serum on top of it, and make sure that we keep them in that lower Dutch range, 0.7, 0.8 to 1 point. I think it's 0.8 to 1.7. DOPS, they were randomized controlled trial. This study was basically criticized because of its small numbers. But what they did show is that hormone users had one half, the MI, heart failure, and death rates than placebo, women who didn't use hormones. These are hard endpoints. These are not surrogate endpoints. And then in the FINISH study, the longer a woman was prescribed and used estrogen-based therapy, the greater the risk reduction. And these risks were the same whether a woman started hormones at less than age 60 or in women greater than or equal to age 60. So you got to take some of this in context. Remember, most of these women were healthy women. We don't always see healthy women, which we'll talk about when we get to the clinical pearls. But here, what about progesterone? Honeysett and Pryor, small little studies, and they found that 100 milligrams, 300 milligrams did not compromise vascular integrity. They are safe. No benefit, no harm. And as you saw in the KEEPS trial, prometrium times 12 days added to a standard dose patch and a lower dose Premarin was also safe. And here, 45 milligrams used ELITE used 45 milligrams days 1 through 10, and it too was safe for the cardiovascular system. So I think that it's fair to say that E2 alone, transdermal estradiol alone, is safe and probably decreases cardiovascular event rates. We see that in the 50 to 59-year-old group. We see that in DOPS, and we see that in FINISH. It may or may not improve surrogate markers, but I've thrown in the kink about baseline serum E2 and urine levels. I would not take postmenopausal women who are, and maybe they've been on standard doses, but as they get older, I would risk stratify them and decrease their doses so that I don't increase the likelihood of a cardiovascular event. And you see here the FINISH study used patches, gels, similar to what is used today. And don't forget, in women with a uterus, protect the endometrium. So start E2-based therapy as early as possible. time since menopause and age greater than 60 should definitely cause pause. Risk stratified, but it shouldn't prevent you from initiating or continuing therapy. So, as you see, we're left with one absolute risk. And we know how to mitigate that risk. The DAC is stacked to where estrogens are beneficial. And I hope I've shown you that progesterones really don't cause harm. Oh, I forgot about that. All right. So now the question becomes, and this will move through rather quickly, do the doses we've just shown that protect the endometrium, are safe for the breast, protect the heart, are those the same doses that relieve vasomotor symptoms, that treat vulvovaginal atrophy, that protect bones, maybe improve cognitive function? Well, the answer is yes. All FDA-approved patch doses relieve vasomotor symptoms. But what I want to point out here is look at these teeny doses that were used by Spuroff in 1996, 0.02 milligrams. Same effectiveness as a standard dose patch. And then Bachman looked at this Menistar 0.014 milligram patch. Isn't available anymore, but it's a low, ultra low dose patch. And it improved vasomotor symptoms by 4 weeks. Similarly, gels, which are the doses are specific to the particular product. These low dose gels also relieve vasomotor symptoms. This by 5 weeks. And I wouldn't look at this as a failure. It takes lots of women, and I would say the majority of my practice, more than 4 or 5 weeks to call me up and say, Doreen, I feel great. They should be feeling better by 4 weeks, 5 weeks, but I don't get anybody saying that you saved my life at 4 weeks. What about progesterone? Well, interestingly, Hickok and Pryor, you'll hear a lot about Jenny and Pryor, looked at prometrium 300 milligrams. They thought, what about women who can't take estrogen? And what they found is that there was a statistically significant decrease in frequency and severity by 8 weeks. Those with the worst symptoms had the greatest benefit. And there was no rebound if you chose to stop progesterone, which, let me pause here and say, please do not stop estrogens abruptly. There is data out there that says if you do that during that first year, there is going to be an increase in cardiovascular events. Not a good idea. What about in replenish? Well, Bijuva is the 1 milligram, 100 milligrams that's approved by the FDA. 0.5 milligrams and 100 milligrams behaves the same way as the 1 milligram and 100 milligrams. It relieves vasomotor symptoms in 4 weeks. But what I wanted to point out was when the same estradiol dose was put together with a lower progesterone dose, it took 12 weeks for vasomotor symptom relief. Again, progesterones help. All FDA-approved patches and gels relieve vasomotor symptoms. OMP 300 milligrams provides relief. Lower doses have not been independently studied. Again, the products that relieve vasomotor symptoms are safe for the breast and the cardiovascular system. Ultra low dose and low dose patches provide vasomotor symptom relief earlier with less tissue exposure than gels. What about vulvovaginal atrophy? It's going to be a recurring theme. Yes, yes, and yes. The ultra low dose patch? Yes. Low dose gels? Yes. 0.375 and 0.75. Both relieve vulvovaginal atrophy symptoms and vaginal parameters. So ultra low dose patches work, low dose gels work, so we don't need as high a doses as once previous thought. Some women may. That doesn't mean all women do. So you want to put the right dose with the right patient at the right time. If they only have local symptoms, consider estriol, DHEA, but I worry about bone mineral density, and I have, well, now clearly if that's their first symptom and it's in the perimenopausal phase, they're not menopausal yet, yeah, local therapy is perfectly fine. They still have estrogen, hopefully they still have progesterone, which we'll talk about, but local therapy is great in those circumstances. Patches and gels work for both. Doses that improve this, both vasomotor symptoms and vulvovaginal atrophy, are both safe for the breast and the heart. OMP 100 and 300 also improve vasomotor symptoms. I suspect 200 does too. And again, I will be a broken record for protect the endometrium. What about osteoporosis? Now, normally patients will tell me, Doreen, I feel better. My hot flashes are gone. My night sweats are gone. I don't have vaginal dryness. I don't have dyspareunia. Patients don't come into the office and say to me, I think my bones are fragile. So really, this is where getting it right and testing is incredibly important. And it's the balance of E2 and progesterone. You need both for optimum peak bone mineral density, which brings me to young girls, adolescents, premenopausal women, and perimenopausal women are at risk for osteopenia and osteoporosis. You must have normal ovulatory cycles. A normal menstrual cycle doesn't necessarily mean a normal ovulatory cycle. And always address the HPA axis. And of course, the gut. I'm not going to leave out the gut. But here, if you turn up the HPA axis because you're running away from a white tiger, you're going to downregulate or turn down your HPG axis, which is going to impact peak bone mineral density and maintenance of bone mineral density as you get older. I clumped these together because pick your patch of choice, an ultra low dose, a low dose, they all work and they're all FDA approved for osteoporosis prevention. And typically, you know, you can get serum levels of 16 to 20 or that same 0.7 to 1.8. I hope I didn't mix those up, Mark. Gels are not FDA approved, and why? Well, because before you can get something FDA approved, a couple of things have to happen, right? You have to show that it's safe. Second, you have to show that it works. And then you have to show that it's better than what you've already got. And these are not better than patches. You need higher doses to achieve the same results as a lower dose patch. So that's why they're not FDA approved. They work, but to get the same effects, you need much higher doses with higher effective tissue levels. What about progesterone? Well, no one knows the optimum progesterone dose to prevent osteoporosis. Those studies have not been done. However, there are studies, and there have been studies in adolescents, pre and perimenopausal women. Genial and Pryor in 1990 did a one-year study where they looked at pre and perimenopausal women over a year, cycles over a year. And what they found is that women who had normal ovulatory cycles or only had one short luteal cycle per year maintained a stable bone mineral density. However, women who had more than one short luteal cycle or any anovulatory cycles significantly lost bone mineral density. This is important. We need to have a high index of suspicion in our younger women. This 300 milligram dose is recommended, days 14 through 27, because it is a luteal dose. And in fact, when they gave 300 milligrams, it did restore ovulatory cycles to normal. Well, to match the ultra and low dose transdermal estradiol's clinical efficacy, you need higher gel doses, have a high index of suspicion, And in postmenopausal woman, the optimum dose for bone protection is unknown. Clinical pearls. So a low dose patch, the Menistar patch is not available, but if you wanted to use a lower dose or you wanted a compound, a really low dose, biased, they should improve vasomotor symptoms, vulvovaginal atrophy. I can't tell you about compounded creams and bone mineral density. The patient will tell you about vasomotor symptoms and vulvovaginal atrophy. This patch is safe for the breast and cardiovascular system, and in young women have a high index of suspicion. Test, don't guess. And I use a cycle map. I don't let patients talk me into this. Oh, doc, can I do the 19 to 21? Or because it's too confusing for me, because if I miss it, then I got to do something else. I like to see the whole cycle. And of course, ongoing surveillance is necessary. And urine may be helpful. What about cognition?
Hey, Dr. Saltiel. Dr. Saltiel.
We know.
Dr. Saltiel, can you hear me? Dr. Saltiel?
Yeah.
This is Amy. I'm wondering if we want to skip
Yes.
through the cognitive section and get to the conclusion so we can get Mark back on.
Yeah.
Everybody will be able to get the slides.
Okay. We know that estradiol is important for the brain. But what we don't know is, we do know that decreasing estradiol impacts memory, impacts attention, impacts mood. What we don't know is if replacing estrogens improve cognitive performance. We hope it does. We believe it should, but what does the data say? No. And let me just show you this and then I'll end it. Most of the studies don't document cognitive benefit or harm. These are randomized controlled trials. These that do is the Cache County, which is a large observational study. These two were very small studies. So let me get through this. And again, progesterone is necessary, it's protective, but there's a wimpy study that says doesn't help. There are the key points. And here's the summary. And let's put it all together. 0.025 milligram patch with 100 or 200 or vaginal micronized progesterone works. Gels are a reasonable alternative. Vaginal hormones are breast and cardiovascular safe. And ongoing follow-up of the endometrium, the breast, the heart, the bones are necessary. And I thank you all for your attention. And I'm sorry I talked too long or too much. Oh,
no, not at all.
The elephant in the room. Sometimes if I stand in the middle, no one even knows I'm there. There's only one study on compounded products, and I'll let Mark talk about that. So what I've come to believe is extrapolate the data when you can, rationalize when you must, always individualize care, and please document why you're doing what you're doing. And women spend a third of their lives in menopause, so it's key that we get this right. It's all yours, Mark.
Okay, Mark, are you ready to go?
He's sleeping.
There we are. I'm unmuted now. Okay. So thank you, Dr. Saltiel. That was great. A terrific view of the literature and what we can conclude from that. So I'm just looking for the button here so I can view my own, share my screen here. Where is that? So I want to talk about monitoring hormones because we didn't really get a chance to get to that yet. What we have shown is that when you're looking at HRT, there's a lot of data supporting its use and affirming it for people's practice. So Amy, the button that's below here is not here now in order of showing my screen. So where do I see that? Help me out here, would you?
Did you find it?
Oh, there we go. Thank you. Show my screen.
There you go.
All right. So that was really helpful, and really helpful not in this presentation. Of course, I've dug through all this data with Doreen since she put it all together, and that process has been super helpful for me in terms of understanding the risks and benefits of HRT. And you always kind of wonder how you're viewing the studies, and what she's done is really comprehensive at looking under every rock. And when we're done with this presentation, we will send you the paper that kind of follows all of this so that you have that. But we've got to test too, right? How do we monitor this stuff? First, you need a good baseline test. So if we're going to test a baseline, we've got published data that says our data when you're not on therapy follows the serum. So it's a pretty good, really accurate way to look at the hormones. And for me, if I'm looking at postmenopausal women, I need a Dutch test or I need an LCMS serum test, because only those two, from what I've seen, are really accurate enough to get down to those low levels and to differentiate between the hormone sufficient and the hormone deficient levels really well. So you want a good baseline test, but then of course this talk is more about HRT. So let's talk about that. The route of administration makes a huge difference in terms of which test is going to work. So I've put together this little matrix that can help you. If you were not following Doreen's suggestion and you decided to do oral estrogen, for example, you'd want to use a serum test. That's the point of this document, is to help you navigate that. And we're going to be limiting that talk here to just oral progesterone, patches, and then transdermal estrogen. So one of the questions that comes up a lot is, you can use serum really well for progesterone when you're not on therapy. Why can't you use it for oral progesterone? Serum and saliva just don't work for monitoring oral progesterone. Two issues, and they're both a killer, is what happens to the kinetics. You go to bed and you take your oral progesterone. You sleep, and 8 hours later, you get up and do a test. You missed everything, right? All the action is happening in serum and saliva while you sleep, right? Here shows the saliva results. The saliva results, this is a second study, looking at the same thing in serum, but adding saliva in, and you can see it follows the same pattern. So you have the same kinetic problem. The other problem that you have is if you look at 2 hours, we retest these samples using a mass spec method, it's actually back to baseline. All of this that you see up here, that's just metabolites that you've made cross-reacting with the assays. So standard assays for progesterone are accurate when you're not on progesterone. When you're on oral progesterone, the values get pushed up by all those metabolites. Not a great idea. So you don't want to use saliva or serum when you're monitoring oral progesterone. What good is urine? Well, think about oral progesterone. In a sense, it's a prohormone, right? Look at all this allopregnanolone that you get following a dose of oral progesterone. And urine testing, while the levels of metabolites you're going to see, because it's going to hit the gut and get heavily metabolized, are going to be very high. So we have a separate range for oral progesterone. And we're looking at what? Metabolites. But remember, the clinical impact is coming from those metabolites. So here's how we can leverage this information. Okay, we're looking at the alpha metabolites here. That's allopregnanolone and that whole family of hormones. And then the less biologically active beta metabolites. So if this patient isn't sleeping well, you'd say, well, look, you're not making as much of those active sleepy hormones. I might give you a little bit more. If she looks like this, where she's really pushing down that alpha pathway and she's not sleeping, something's going on, right? So go look at cortisol, go look at melatonin, but don't just jack up her progesterone dose in a case like that, because one of the things that John Wiebe showed is this is breast cancer cells. It's in vitro, so I don't know how useful this data is because it's never been followed up on, but that's what breast cancer cells do when you expose them to alpha metabolites. Yes, they help you sleep, but there is a little bit of a concern potentially with breast cancer risk if you really push down that alpha pathway. So I think that feedback is useful. So when you do the Dutch test and you're using oral progesterone, that information, the metabolite picture, how does it get metabolized in the gut, is going to be useful. Now, what Doreen said pretty convincingly is transdermal is the way to go with estrogen. Well, okay, then how do we monitor it? First thing you've got to do is people get really confused about the monitoring. And if someone says, hey, you should use saliva testing, what they're going to show you is a bunch of data about progesterone. And we could dig through that in a separate lecture, but you have to separate progesterone from testosterone and estradiol if you're going to make sense of the transdermal data. Okay, so the urine data looks really nice there. And we can see here that it scales up linearly, and you get a similar pattern whether you're using patches, creams, or gel. Low dose, mid dose, high dose. Now, when you use saliva testing, this is data that I helped publish in an abstract years ago, you can see that with these same doses, where we're just out of the postmenopausal range in urine, same in serum, the saliva is way outside here, outside the premenopausal range, and that's 24 hours after therapy. That's when you're ready for your next dose. So the rest of the day, it spends up in here. So you get a lot of hormone in saliva and just a little bit in urine or serum. So the salivary response greatly exceeds the response in serum or urine, right? Saliva response is huge. So which one's right? And we want to figure this out. You got to ask the clinical data, right? One thing we don't want to do is just ask our patients. This is a mistake I think that people make, is if they're using a dose and they just rely on anecdotal evidence, you really can't do that. Here's some hot flash data. Look how good this works. Over 12 weeks, it gets progressively better and the hot flashes get better, right? That's the placebo arm of an estrogen study. So we really need to look at placebo-controlled studies for estradiol in order to really make sense of which test is really aligning with the clinical data when we use therapy. So what I did is I dug through all the studies I could find. And I said, show me the studies that lead me to the conclusion that the bone mineral density in this case is aligning, the change in the bone mineral density is aligning with what happens to the serum or the urine. And when you read the studies, that's the direction they point you. We don't see any studies, I haven't found any studies that say, no, the serum and the urine aren't moving, but we're seeing an increase in bone mineral density, right? If that was the case, the saliva data might be aligning better with the clinical data, and we just don't find that. With vasomotor symptoms, we see the same thing. With vaginal atrophy, we see the same thing. And what this really means is when we look at these lower doses of transdermal estrogens, we say, okay, the saliva is telling us this is a lot of estrogen. You're spending all day in a supraphysiological state in saliva, which tells you, wow, that's a lot of hormone. But when we look at the serum and the urine data, this is what aligns with the clinical data. So let me explain this. If you take estradiol, and they've done studies on estradiol, when you put a woman on 0.27 of estradiol, the value doesn't come outside the postmenopausal range. But again, the saliva value is very high. Well, what happens to vaginal atrophy? It didn't get any better compared to placebo until you gave more estrogen, at which point the value comes outside the postmenopausal range when we expect to see increased symptom relief. Now, bone's a little harder, right? So when they tried 0.75 of estradiol at this dose, the bone mineral density got a little bit better, but it failed to match the efficacy of even a low dose patch. If you used a higher dose where we're getting close to the premenopausal range, that's where you get full sort of relief of the symptom of having your bone mineral density increase equivalent to what you see in a patch. Now remember, the saliva data is sky high even down here, so it really says, oh, that's too much hormone. But when we look at the clinical picture, it says, no, the serum and the urine are accurately reflecting the type of symptom relief we get from hot flashes, from bone mineral density, and from vaginal atrophy. So the point is, when we look at this point right there, where the data is outside the postmenopausal range and not yet in the premenopausal range, that's the sweet spot, whether you're using patches or gels, and we presume creams. As Doreen said, she's not being biased against creams in this presentation, right? There isn't any data, and that's not an anti-compounding message. It's just a reality that nobody has actually used those products to look at clinical outcomes. Now, why would we want to use urine instead of serum? Well, one reason is because the up and down pattern in serum can be pretty fast. So you hear people say a lot, when I use a cream, I don't see anything in serum. Sometimes it only lasts for a few hours in the serum. But when you look at a true 24-hour average, as you're going to see in a urine sample, you can see here the data makes a lot of sense, that as you use the doses that we expect to see symptom relief, the values are increasing, and it's going to be a better number because it's an average over time instead of just a snapshot in a moment. With a patch, that's fine because the patch is flat throughout the day, but creams and gels, they're going to move around. Urine's going to be a nice option. The other reason we like urine is it adds the metabolites. So look at this patient. She's got high estradiol, right? So here's the premenopausal range here. She's outside that range. But what do you notice? The pathway to 2-hydroxylation seems to be a little bit plugged, right? It's low for 2-hydroxy and all the other metabolites are elevated. Well, we know what opens that 2-hydroxy pathway, right? DIM, I3C, and look what happens when we open that with some DIM is the 2-hydroxy estrogen. This is a before and after DIM case. 2-hydroxy increases, which makes us feel better about breast cancer risk. 4-hydroxy in this case goes down. It doesn't always. All of these metabolites came down because why? We opened up this channel, and we can more strategically look at women's estrogen levels and balance them, sometimes by just altering metabolism, but only if we're actually looking at the metabolites. And that's really one of the big benefits of urine testing. So Doreen's letting you know what we should do in terms of treatment. In terms of testing, serum's a good option for patches. It's okay for gels. I wouldn't really advise it with creams because that up and down pattern hasn't really been characterized very well. Use LCMS, not an immunoassay for these low levels. Target about 20 to 40, maybe as high as 60, and don't use it for oral progesterone. With Dutch, it's a great option with oral progesterone and any transdermal estrogen product. You're going to want to get right between the pre and postmenopausal range, right? So for us, the postmenopausal range is down here. The estrogen replacement kind of target that I think makes a lot of sense is right in there. That, and you know, shoot a little higher if you're looking for a little more impact, but you don't need to get up into this middle of the luteal range, right? We know that from the studies. You don't have to push that high in order to get clinical symptoms improving. And then you're going to want to monitor the metabolites. So the other benefit of Dutch is you just get to look at all this other stuff, right? You get to look at the cortisol pattern. You get to look at metabolites of estrogen and androgens. We've got B6 marker, B12 marker, glutathione deficiency marker, oxidative stress marker, melatonin. So that's really one of the main benefits of Dutch is, yes, it works for a lot of hormone replacement therapy monitoring. And when you compare it to what functional medicine doctors have done a lot, which is to get sex hormones out of serum and then move over to saliva to look at cortisol, you're going to get all that with Dutch, plus a whole lot more. So it's a really cost-effective way to be monitoring hormones, whether you're on therapy or not on therapy. And I'm really, really thankful that we had Dr. Saltiel here and able to share this. As I mentioned, we're going to also share the Word document that really lays all this out in terms of benefits and in terms of risk, so that you can really just have the confidence in your practice to know that there's a safety net of good literature to support the rationale that you need to have in terms of your practice. So that concludes our talk. I wanted to just give a minute to see if we had any questions that we want to add into the mix. I think Amy was going to run some of those down.
Sure.
Do you want to just do those?
Yeah, Mark, I've got a couple here for you, and then I've got one or two for Dr. Saltiel. So I've got someone asking, what about E2 injections and the Dutch test?
So injections are usually easy. When you give an injection, every lab test goes up sort of proportionately. So I don't see a lot of them. With E2 injection, really the question is just when to test, right? The urine is going to reflect those values well, so will a serum test. If you give an injection weekly, I recommend doing it right in the middle. And that's generally what people do, although like I said, it's not super common with an injection. Next question.
Mark?
Yeah, what's the next question?
Okay, the next question is, what about testing and compounded sustained release oral progesterone?
So with oral progesterone, you don't get as much information as you want, right? What do you want to know? Systemic progesterone levels. You can't have that. There's no test that really shows you that. The urine and the serum aren't going to be accurate for the reasons, the serum and the saliva for the reasons that I explained. What does the urine tell you? It doesn't tell you systemic progesterone levels. It tells you how you're metabolizing. It gives you good feedback for the sedating effects of oral progesterone. If it's sustained release, it just impacts the kinetics of how long that progesterone is going to hang around. But the only question we really get to ask with the Dutch test is, how are you processing that progesterone? And that does impact your decisions in terms of dosing. But the fact that it's sustained release doesn't really change the picture all that much. I'm not saying sustained release doesn't make sense. It can make a lot of sense to draw out that oral progesterone throughout the night a little bit more, but it doesn't really change your testing options or the information that you get from the tests.
Mark, can you still hear me?
Yep.
Okay, what about pellets and the Dutch test?
Pellets are kind of like injections. They lift everything. So then the only question becomes, when do you test? And I think with pellets, you're not taking them out, right? So if you make a lot of 4-hydroxyestrogen, you're going to want to know it. If you're not methylating, you're going to want to know it. So I think testing after it kind of settles in, maybe 4 weeks, something like that, is not a bad idea, especially the first time around. The first time you put a pellet in, you really want to see what's what's going on. So the Dutch test works well to monitor those levels. Serum works pretty well too. You just don't get the metabolites. And for me, with a pellet, I really want to know how the woman's metabolizing it, because you can intervene, right? If she's got, let's say her metabolism is even great. Her metabolism looks great, but her levels are higher than you want. Okay, add a little add a little DIM, add a little calcium D-glucurate, and you can flush that estrogen out a little bit quicker. We just did an analysis of our data, and what we found is that if you have a woman on a patch and you add DIM, you're basically taking her down by half a dose. So if you go to 0.05 with a patch and then you put her on DIM, the estrogen levels you're going to see are about the same as a 0.0375 instead of 0.05. So you can do the same thing with a pellet. You say, oh man, it's running a little bit hot. Okay, well, if you add in some help getting rid of that estrogen, and then next time you put the pellet in, lower the dose a little bit. I think that's really good feedback. So Dutch works great on pellets, I think, and I highly recommend it in that situation.
Okay, what about an E2, E3 testosterone troche with oral progesterone and testing?
Troches, you can't test troches. You can use them. The testing does not help. So why? Serum's too fast. But there's a nice study where they looked at troches of testosterone in women, and by 2 hours they were a baseline. Like, there's just no way to test that, right? So the urine test would work really well because it's an average over time, and it swoops in and saves the day. Except if you swallow any of that hormone, which you almost always do, the amount you swallow floods the urine at levels that are higher than you would get from that same dose if you got it truly sublingually. So I own a urine lab, and I'm telling you, urine testing doesn't work very well for sublingual. So you can just take my word for it. You can try to not swallow it and this and that, but I just think you're flying blind with troches. And I'm not saying don't use them. If it works clinically for you, okay. The urine will tell you how you're breaking it down. Am I making 4-hydroxyestrogens? Am I methylating? All of that. But to say, oh, did I get the dose right? There really isn't a lab test to help you get the dose right for pellets. The oral progesterone that you're throwing in the mix, as I said, that's fine. You can get some good feedback on that. But the troches, there's just no great way to test them.
So this question's for Dr. Saltiel. Why or why not are you a proponent for testosterone for women? So are you for testosterone replacement for women, or are you not in favor of that?
Oh, absolutely, I am in favor of it. I've had so much information to talk about that testosterone needs a whole separate webinar. And in reality, I use testosterone pellets, and they work very, very well in both men and women. When it comes to estrogens, I typically don't pellet unless the woman's had a hysterectomy, and I know how she's metabolizing estrogen, because in women with a uterus, I just get concerned. And I just want to kick in just a little bit on the progesterone question. When somebody asked about oral micronized progesterone extended release, the real question you have to ask when you're going to test progesterone is, what question are you asking? Are you asking if I have the right dose? Well, in women with a uterus, no test is going to tell you that. You can certainly look at the data that did endometrial biopsies for reassurance at doses that work, as long as you're balancing with a low enough dose of estradiol. But really, no test is going to tell you whether you're protecting the endometrium unless you extrapolate from the data or get an endometrial biopsy. Even a transvaginal ultrasound, a normal stripe, doesn't rule out endometrial proliferation and or endometrial hyperplasia in certain areas. And Vashist in his study talked a lot about normal transvaginal ultrasounds and endometrial hyperplasia. And so, yes, I love testosterone. I use it with estrogen. So to answer the question directly, and I tell it. And I usually do Dutch about 4 to 6 weeks later.
Great. So one other question here, Dr. Saltiel, for you. Have you ever seen studies showing marked hormonal drops? So like the hormones dropping, the progesterone hormone or other hormones that have resulted from a PTSD in patients and their neurocognitive health? So essentially hormones and
Yes.
What's affecting with any type of PTSD.
Yes, because if the HPA axis is not addressed, that's going to directly impact hormones. Absolutely, without a doubt, I've seen that a lot. And so you have to address the underlying HPA axis. You can certainly support them with appropriate hormones. But again, address the underlying etiology.
Okay, this question's back to Mark. Mark, what about oral pregnenolone supplementation for increasing progesterone? And actually, either one of you could probably address that.
Yeah, the first off, Carrie texted me and said I said there's no good test for pellets when I meant to say troches. So if I said that, I misspoke. Troches are tough to monitor. Pellets are easy to monitor. So pregnenolone works in the brain. If you want to use it, but it does not increase progesterone from anything I've seen. However, pregnenolone is illegal in the Olympics, and when people take it in the Olympics, the way they test for the fact that you're taking it is to measure the same progesterone metabolite that we measure for progesterone. So what I'm saying is, if you take pregnenolone, it goes into your gut, gets turned into this progesterone metabolite, and spills into the urine. So it's going to look like your progesterone is higher, but that's not what it means. It just means, hey, you took some pregnenolone. So for our test, you got to get off pregnenolone for a couple days to just basically get it out of the way. If you want to increase progesterone, pregnenolone is not the way to do it. The ovaries don't make progesterone out of pregnenolone, right? They pull in cholesterol, and right in the ovary, they make progesterone. And one of the intermediates that's in that tissue in the ovary is pregnenolone. But circulating progesterone or pregnenolone is not used to any significant amounts, as far as I know, to make progesterone. It's an intuitive concept when you look at the steroid cascade, but it's not circulating pregnenolone that you make progesterone out of. But on our test, any progesterone metabolite you see from the pregnenolone doesn't necessarily indicate circulating progesterone. So you just want to get off of it. And if you want to monitor your actual pregnenolone, a blood test is probably the best way to do that, not a urine test.
So this will be our last question. I know we've kept everybody about 30 minutes over here. So last question is, and Dr. Saltiel, you might be able to address this one. Can progesterone orally be given daily in postmenopause or only biweekly?
It could be given. It should be given daily.
Okay.
Are we talking about oral progesterone? The answer is yes.
Yes,
daily.
oral.
If
It
we're
was oral
talking about,
progesterone.
yes.
Okay.
daily. Absolutely.
Okay. I think we're good, guys.
Great. Well, thank you everyone for joining us. Thank you so much for Dr. Saltiel, not just for joining us, but for spending literally months in the literature to put this together. I think it's been a real gift for those who are listening to have this organized. And again, we will send out supporting documentation so that you have it. And if you have any other questions, feel free to email us and we'd be happy to answer those. So thank you very much, everybody.
And along with that, everyone, we will be sending the recording and a copy of the slides to all of you, along with what Mark was talking about. We should be sending that out tomorrow afternoon. So thanks again, everyone.
Thank you.